Pekné dobré ráno.
Pleasant good morning.
Vítajte pri dnešnom
Welcome
webinári,
to
ktorého
today's
hlavnou
webinar
témou je
with the main
plán
topic,
obnovy
which is
v zdravotníctve.
plan
Dnes
of
buďme
resilience
rozprávať o
and
hodnotení
recovery in
Európskej
healthcare.
komisie.
According to the
Výsledky
evaluation
slovenského
of the EU
zdravotníctva
Commission,
už
the
niekoľko
results of
rokov
the Slovak
zaostávajú za
healthcare has been
porovnateľnými
falling
krajinami
behind
Európskej únie.
the
Zdravie
comparable
Slovákov
countries
sa
of the
zlepšuje
EU. The health
pomaly
of
a
Slovaks
Slovensko je
is
dlhodobo
improving only
kritizované.
slowly, and Slovakia has been criticized for high level of preventable deaths. There's poor prevention in healthcare and primary care. American Chamber of Commerce also wants to contribute to this discourse. The Committee for Healthcare of AmCham prepared a professional statement on the recovery and resilience facility, plan of recovery and renewal, as we call it. But we'll get to that very soon. For English-speaking friends, please on your right hand switch to English. And you can also join the discussion through Slido today with hashtag RRF Recovery and Resilience Facility 2021. So RRF 2021. And before we introduce the guests, I'd like to thank to our partners who enabled this discussion webinar. AbbVie, AmCham, Biogen, Janssen, Johnson & Johnson, Medtronic, Novartis, MSD, and Roche. Thank you very much. So let me introduce our guests. All the guests are here online, so they're remotely connected to us, but hopefully we'll manage this as well. One of the guests is Ludmila Majlát, the economic advisor of the EU representation in Slovakia, of EU Commission representation in Slovakia. Oskar Dvořák, General Director of the Reform Agenda Section from the Ministry of Health. Good morning. Peter Balík, General Director of the Section for Innovation, Strategic Investment Analysis from the Ministry of Regional Development and Informatization, or Digitalization. Lukáš Stanko, Project Manager from the Section of Recovery Plan, Ministry of Finance. Katarína Fedorová, General Director of Section from the Ministry of Social Affairs and Family, and Labor and Family. And Miriam Aponíková, Director of Roosevelt Hospital in Banská Bystrica. Good morning. Marian Schott, President of the Association of Private Physicians. Good morning. Anna Ganamová, Director of the Association of Providers of Social Services. Welcome. Thank you. Good morning. And Robert Babela, Head of Medical Disciplines of the University of St. Elizabeth. Good morning. Good morning to you too. So, you can also vote on Slido. What do you think is the key problem of Slovak healthcare? We will certainly check on that voting later on. And this is my question. Let me think, who shall I start with? Ms. Laponíková, you're directly in the field. Roosevelt Hospital. What's the biggest problem of Slovak healthcare? Well, that's really a direct question. The key problem of Slovak healthcare. Wow. Well, you can't answer this with a single sentence. I could say that this relates to the overall situation in Slovakia, the status quo, and there's a little bit of chaos that is getting it also into the practice in the field, and the only thing that helps is that people who really work hard, they try to do the best job. That's the only savior, so to say. Well, we'll be talking mainly about money today, especially about the RRF, Recovery and Resilience Facility. And by the way, there's this information that there should be 1.1 billion euro for acute care, 100 million for mental care and long-term care, 250 million euro, just briefly. So let us look at what's missing, what's not missing, and the key question is this the beginning of a healthcare reform? Well, I hope it is. Now I heard you. The original question, that was the key problem of Slovak healthcare. I believe that it's easier to define in Slovak healthcare what isn't a problem, because there are so many problems. They are related not only to financing of healthcare and efficient usage of funds or resources, which even 1 year after some changes, it's still inefficient. There are issues related to healthcare infrastructure. This is basically the essential stumbling block of Slovak healthcare compared to other countries. It's also the factor where we are falling behind drastically. Another problem of Slovak healthcare are not just the facilities, but also patients themselves. It's very important that the citizens of this country focus more on prevention, prophylaxis, to gain education and knowledge about how to prevent diseases, whether civilization diseases or other diseases, and for this they need to behave responsibly. So there's quite a few problems on any side of Slovak healthcare. So Peter Balik said that prevention is one of the key things that we're really falling behind in terms of the EU. But the EU Commission has defined the biggest problems of Slovak healthcare. So what's the opinion of the Euro Commission? Thank you very much. Yeah, European Commission on a regular basis assesses all the member states, including Slovakia. It publishes the report and recommendations, and this process has been happening for the last 10 years. So it's been an ongoing thing, and this is going to be, of course, included in the evaluation of the RRF. This assessment related to low level of cost efficiency. Cost efficiency of the overall system is a problem in Slovakia. Equally, another big problem we perceive and that will have to be tackled is the need to create a strategy to address the problem of lacking personnel, because we gradually see a lack of staff. This doesn't only concern physicians but also nurses. When it comes to physicians, the statistics are comparable to the EU. We are lacking specific medical specialties, but in Slovakia we have a problem with regional distribution of physicians. They are mainly lacking in the countryside, and many of them are aging. They are before pension. And another problem related to this is lack of nurses. Slovakia will be lacking 9,000 nurses very soon, and that's one of the biggest problems we are going to face. It's going to hit us very soon. Talking about efficiency of the system, cost efficiency, or lack of it, there's too much emphasis on hospital care. And less is being told, or there's limited role of primary outpatient healthcare. And looking at the system as it is, and looking at the outputs or deliverables of the system, which is what people are interested the most, and that's health of the population and medium longevity, which is increasing, but we are still falling behind the European average. And then looking at the education of the respective groups of citizens, also depending on the level of education, the medium term of longevity is lower, especially looking at the marginalized Roma groups. They are on average live 10 years shorter than the majority of the population. Also, people with elementary education live shorter lives. So there are huge disparities across the socio-demographic groups. And the most frequently repeated indicator that we often mention is the high rate of preventable deaths. So there's huge space for improvement in preventable mortality. People die even though they could be treated. And statistically, Slovakia is really almost at the top in this indicator, which is bad, of course, at the top level of preventable deaths. Mr. Stanko, you're from the Ministry of Finance, so I suppose that your role is mainly to look at the financial sustainability of this plan. Perhaps someone who saw the plan may think, well, great, we're going to pour millions and millions of euro again into healthcare, financing in debt relief of hospitals that take on new and new debt every year. So what's your take on this? Thank you for the question. Well, we are trying to make sure that the hospitals are sustainable in the future, whether from the methodology or legislative perspective, to ensure full value implementation. We have National Implementation and Coordination Authority. And all of my colleagues who are working on the resilience plan or recovery and resilience plan, 34 of us, they actively communicate with ministries, external stakeholders, and the public to explain what are the influences and what outputs should be implemented within the framework of the RRF, so that we focus on the sustainability, also financial sustainability, which was in your question, because this is one of the priorities of our section and one of the political priorities, so to say. So that's to ensure that the finance or funds are distributed where they are necessary and investments are done in the sustainable way. Ms. Laponíková, you're the director of a hospital in Banská Bystrica, which is one of the leaders by example, but there are hundreds of millions of debt relief for other hospitals every year. Now we hear that the RRF should also include investments into infrastructure, which is understandable, but what's the risk? Isn't it unfair for your hospital that doesn't generate debt and that the other hospitals that do generate debt will be relieved again? Well, thank you. We need to look at this from the comprehensive perspective. Honestly, the whole RRF, regardless of who sits where, it's all a political decision. And the political decision, obviously, has some consequences. I don't perceive this personally. I don't perceive this unfair. Because the plan doesn't say which hospitals will be invested in. The essential thing is that there's willingness to invest in infrastructure, because the infrastructure is outdated and it needs investment. We can only be happy that some hospitals will be reconstructed, maybe new hospitals will be built. Maybe I would move the context to a different area. I see major limit in the time horizon for the implementation, the deadlines, because the best practice also from other countries, as I looked, example is the hospital Bory in Bratislava. Preparing such a large project like building of a hospital, it takes several years, and it's all related to the applicable legislation, and obviously we're not going to eliminate this legislative burden fully. So the construction of Bory has taken 6 years until now, and it's going to take 1 or 2 more years. So it doesn't really matter what's the political decision, because anywhere you look, you need to renew the infrastructure. But what is going to be essential? Are we going to be able to manage this in such a limited time? So that's the challenge here, the implementation. That's going to be the key aspect of the whole thing, and this is where I see emphasis needs to be taken. And can we do this without thinning the herd, so to say, without limiting the number of hospitals? Because stratification of hospitals wasn't passed even by the previous government, and this government, the incumbent government, is not even talking about it. Can we do it without it? Yes, you're right. We can't do it without stratification of hospitals. Maybe this is going to sound weird, but during communist era, it was well tackled, it was well established, and we are somehow returning to this model. I know it sounds weird, but yeah, it was well done compared to today's situation. We've been talking about stratification for many years, that's right, and now we have a unique opportunity that gives us enough time, there's enough political space, because the political aspect, it needs to be emphasized, so we have space to move somewhere. I believe it's a shame that we can't take advantage of the potential we have, judging from the documents available to us, and it could be used rationally, because the fact that people in the field have agreed on some outputs, and the outputs are here, it's a shame. Our shared shame that we don't want to use the data that we have on the table, and we hinder ourselves with next work, and for the shortness of time it's useless work. So if I understand you correctly, every government prepares their own strategy with their own conclusions, and these conclusions are the same for every government because the problems are the same. Well, you said it very pragmatically. I tried to be nice and diplomatic, but you are correct, yes. Okay, thank you. Mr. Schott, one of the things which is in the RRF is the primary health care, and the fact that we don't use it sufficiently, that GPs, Mrs. Lapuníková mentioned this, Ms. Majlatova agree that we have primary health care which is not working, we have prevention that is not working, we have a network of GPs where these GPs are either aging, they're going to pension, or they don't want to work in remote areas. It's easy to understand, but do you think the RRF is going to tackle this? Well, let me start globally. When I looked in detail in the RRF, the Recovery and Resilience Plan, I recalled how the governments were coming and going, and the health ministers were coming and going. And what was the most radical thing was these 27 reform areas that were introduced by Minister Drucker, then stratification of hospitals, and now we have a new government, a new recovery plan. So we need to say that the good thing is that the issues are described in a decent, professional way. But unfortunately, I have to say, I'm skeptical whether this recovery plan will actually be implemented. Just like the director Lapuníková said, to make sure the implementation is truly executed, that's a question. And there's a big stumbling block in relation to the deadlines. I'm not quite sure, I'm not quite identified with how it was done. And my predecessor in the Association of Private Physicians, we repeatedly emphasized that we have physicians who are aging, they are old, they are getting older, we are ourselves, we're getting older, and we perceive this, that this renewability of the staff, of the ranks of physicians and nurses is really a problem. And this is the biggest problem we're going to face soon. And looking at what we're talking about on and on and on, efficiency and cost efficiency in healthcare, well, we still have lack of sources, lack of funds to saturate the healthcare. As such, not only talk about sufficiency, but there's lack of funds, because I keep hearing like, we returned 10 euro to you, but we want 20 euro back from you. You know what I mean? So we still haven't got to the horizon of tackling the healthcare as such. We still talk about the costs. And thanks to Ms. Majlatova for mentioning that the primary healthcare is important, because it is. In Slovakia, it's a habit. I don't want to insult hospitals, because they are a very important part of the healthcare system, whether private or state-run hospitals. But we need to say aloud, you know, patients get to hospitals only based on referrals. Someone had to check them, diagnose them, and refer them to hospitals. And the hospitals are there to treat the patient and cure the patient or finish the diagnostic, etc., etc. So, from this perspective, I do appreciate the alternative that the pre-hospital healthcare is very important before the patients get to hospitals. And I need to say that this is a small brushstroke on a huge painting. This whole recovery plan is just a small piece of mosaic that needs to be performed. Personal changes, possibility of getting into the system as a doctor, as a healthcare provider is very important. And the Ministry of Health needs to implement what we've been talking about for so many years, to start talking about healthcare stuff, so that these human resources are involved in the system. So, to answer your question, yes, it's a small piece of mosaic of what should be done. And when there's enough space, we can talk about the reform of the optimal network of healthcare facilities, of outpatient medical offices. So this is the summary of the whole system for me. Well, okay, but if we pour more money into the system, you say one of the biggest problems are the human resources, so there's not enough physicians, simply said. So even if we pour more funds, more and more money into the system, I suppose that some of the problems may be addressed, but the essential problem of not having enough physicians will not be addressed, right? Well, I need to return to prevention. In Slovakia, there was a very good system of preventive checks, and there is a system which is still running. I myself was fighting with the ministry for so long to not change the program of preventive screening and preventive check and not change the strategy. So I would be happy if we continue in the preventive check program as it is set up. It's more or less good. And looking at the HR question, yes, we've been dealing with this again and again. That's why I'm saying that this recovery resilience facility is just one small brushstroke on a large painting, because it's just one cog in the machine. I mean, the more more funds in the healthcare, the more qualified and more professional healthcare staff is going to be there. Just a small calculation, the amount which is on your slides, per 170 new medical offices which are needed into system. And if you calculate this, I'm not great at maths, but if you look at the 10.5 million divided by 170 healthcare offices divided by 5 years, the amount per single medical office is approximately 1,000 euro per month per single medical office, which is not even enough for the rent, not talking about the wages of physicians and nurses. So if we want to establish medical offices as greenfield projects, 1,000 per month, well, that's very, very little. And I don't think that for this amount anyone will go into the regions or into the countryside to be a doctor or a nurse, a GP. Oh, okay. Mrs. Majlatová, if we compare how Slovakia addresses the RRF compared to Czech Republic or Estonia, so countries which are comparable in terms of size and in terms of economic development, so how these countries approach the recovery plan and how do we approach it? Well, for the start, let me give you a couple of statistics. The date of prolonging the RRF submitting of RRF is 30th April, so we have 1 month to submit the plan. So far, we've been consulting with the Commission. 20 countries are in detailed or in close touch, and 3 or 4 countries haven't submitted their plans. They're at the initial stage of consultations, and there are 2 countries that the discourse is at a very general level. So when it comes to preparedness of the respective countries and the RRF, I would say that Slovakia is in this better group, more successful group. That we've had the first consultancy, now we are in the middle of the second consultancy with the Commission. So there's great likelihood that the plan is going to be completed and it's going to be good. The key thing, the plan is going to be evaluated based on specific criteria, but what we want to see in those plans is that they represent an interconnected package of investments and reforms. And this is what we are discussing. I mean, the investment as such is not enough. They need to be linked to reforms to change the system, whether it's about hospital care, stratification of hospitals, which is an example of a reform which is key, so that there can be some investment. Because first we need to know where, how many hospitals, so that we can fund them or invest in them. So there's a first essential condition. So we want to see the connection of investment and reforms. And this recovery plan is going to start up the reform process, because in those 10 years, the Commission recommended those reforms, but these were just recommendations. There were no money in the package, so the reform process failed to start. And one more important element, following up on the implementation discussion. Yes, I need to confirm that implementation is going to be difficult and demanding. demanding because the mechanism is totally different from other mechanisms. It's different from cohesion policy facilities because the reimbursement is going to be established based on achieving milestones and objectives and not based on invoices as we are used to in cohesion policy. So the demanding character of the plan represents that there needs to be specific objectives and estimated investment cost, which is a very difficult exercise. And the objectives, let's say stratification of hospitals, we not only need to elaborate stratification document, but it needs to be established in the legislation or passed in the legislation. And if we achieve this, based on this stratification document, and if there's finance attached to it, then the payments will be reimbursed. Or Slovakia wants to build several hospitals. Well, the reimbursement will be based on how Slovakia will be achieving the number of hospital beds that were included in the recovery plan. So the plan is very demanding and needs to be very well prepared. The objectives need to be executable, and of course it needs to be prepared well. And the implementation stage in itself is going to be a challenge because investment projects, this public procurement legislation, there's lots of stumbling blocks on the implementation level. Second thing, this needs to be supported with enough of quality people who know how to build hospitals, who know how to manage the process of building hospitals, and the flow of money, as you mentioned, is the volume of money is more than €1 billion. That's a huge investment. It's a huge opportunity, but also it's a huge commitment. It needs to be prepared well and implemented well. Ms. Majlatova, how this can be complicated by this coalition crisis, So let's try to imagine that the government falls. I mean, it's one of the possibilities. So there's going to be a new government. This is under process. There are political commitments. There's stratification involved. I mean, how these tight deadlines can influence the whole thing. All the speakers have mentioned the deadlines as an issue. So, well, we look at it purely from a technocratic perspective for the moment. There's the deadline to send the official plan by the 30th of April. If nothing changes, the commitment will be linked to those priorities that are in the plan. If it's approved by the Commission, within 2 months, plus then there is the approval by the Council, then it becomes binding. Then it can't be changed anymore. Then we will only follow the milestones, fulfillment of the milestones. And if 1 year down the line Slovakia sends the report that it has achieved the milestones, we'll check whether the milestones are truly achieved or not. And if they are, the money will be there. If it failed to achieve the milestone, there will be several months for amendment or for remedy. And if it doesn't, within, I believe, 18 months, the whole allocation is under threat. So it's possible that there will be no money coming to Slovakia. So the plan is so binding that when it's sent to the Commission and the Commission approves it, it's either implemented and the money will be sent to the state, or it's not implemented and the money might not come at all. So right now it's the interdepartmental amendments procedure. There are various roundtable discussions. The Minister of Finance, who is responsible, is discussing about the whole topic, how much the overall plan can be changed within the scope of this interdepartmental amendments procedure. I mean, we know the details of the plan, so can it be changed at all? Well, at the moment, yes, there's the amendments procedure between the respective departments or ministries, and we have over 2,400 comments, and more than 1,300 are material comments in relation to various aspects of the plan. We're looking at all these comments, and if they are constructive, and if we can incorporate them into documents, if they are helpful in achieving these set objectives in terms of implementation or in terms of the overall concept and purpose of philosophy of the reforms, then we are going to incorporate them, of course. So it's not going to be changed essentially, right? Well, we can alter the plan within this commence procedure, but probably not. There are probably no material changes expected. If any comments make sense and we can incorporate them, we will incorporate them. Of course, there will be ongoing communication with the respective ministries, but the essential, substantial part which has been prepared shouldn't be changed dramatically. We obviously appreciate all the comments we received. We try to be as constructive as we possibly can be. And we appreciate our stakeholders that they want to help us, and we believe that this is going to be successful. This comments procedure is going to be successful. Well, we have colleagues here whom I haven't involved yet, because we've been talking about the primary healthcare and hospitals, but long-term care is a very important thing, and it's been long-term neglected, by the way. So, Ms. Fedorova, what are the key issues in terms of long-term care? Thank you very much. Well, this is true that in terms of long-term care, we are really falling behind. Just like in healthcare general, long-term care also has been neglected. Whether we're talking about funding, capacities, surveillance, there's serious space for improvement. We owe these the people as providers of long-term care, but also the customers, the recipients of long-term care. We owe them a lot. So I'm very happy that this recovery plan that I perceive as a start of the whole process of reforms, I'm very happy that this plan also involves long-term care, so that it gave us more courage, or is more encouraging to reform these processes. So we hope to start it up. But as I said, the recovery plan expects to extend and build capacities. So investments into capacities of long-term care, that's going to be great. But that is not enough. It's not enough because we need to also reform of assessment and reform of financing of long-term care, and of course reform of surveillance. Talk about surveillance, we need to mention that this is a reform of the changing of finance, so that money will follow the client. But it's not the only thing, or the only issue in relation to financing of long-term care. It's a complex, it's a package of issues. It is just a starting point. Ms. Ganamova, you're the director of Association of Social Services Providers. What do you like about the resilience plan, and what is missing there? Well, what I like about the plan is that it deals with renewal of the facilities, and that it will include surveillance of long-term care, but not only in residential care, but also in non-formal, informal care, that there's going to be emphasis paid on education, on informal carers, because as I mentioned, there should be equal care, is an equal right and equal responsibilities by formal and informal care providers, and also clients of formal and informal care. But what is missing essentially is, we've seen 11 years of heavy fight to eliminate the discrimination of public and non-public providers. But we shouldn't see the directors and providers of the care, but we should see the clients, the recipients of the service, who are discriminated because they have no right to equal share from public funds, because the first government of Smer, social democracy, by the act from 2008, took away 1/2 of the contributions from the non-public providers and non-public clients. And it only got to the level from 10 years ago, just last year, whereas the costs have been increased by 160%. These are incredible figures. And if we look at the European level, we are a member of the European Association of Social Services Providers. And when we explain to our European partners what we've been dealing with for those 11 years, years. They just don't understand how it's possible that the non-public providers of social care actually exist in Slovakia. So what I'm missing here is, in terms of reform of financing of long-term care, is the integration of financing for private and non-private providers. So I'm missing an assurance or guarantee in the name of the document, but even in the text itself doesn't mention the guarantee of assuring us about the equality of funding. So it's this essential fight that we've been fighting, mainly our association has been fighting. It seems to be ignored for those 11 years, and the responsibility for the whole generation of politicians, and I'll be very open now, or one part of the employees at the ministry are professionals. They have no political responsibility, but one part of the healthcare ministry employees was involved in the discrimination and failed to protect the rights of the clients of these long-term care facilities. So I'm very worried that there's no guarantee mentioning elimination of this. And point 4, that's very important, that's the courage to reform, decentralize and redistribute competence of social care service providers. And since the system showed to be fully inefficient, the competence provided to self-governments and local governments, the self-governments are failing. I mean, in those past 11 years since the reform, we took over some of the responsibilities because the municipalities were failing to pay any contributions. First, it was the flat contribution, €120, but later it was changed, and it turned out that 1/3 of people eligible for long-term social care died before receiving a single euro from public funds. 1/3 died before they received a single euro to which they were eligible. Because majority doesn't even understand what's the terrible state of play. So now we are the plan of recovery is expecting to improve the funding. We're happy about the new direction. We also support the idea that it's going to be linked to a specific citizen, which is good, even though it's partly also doing this. But there's a flat rate amount from all resources across the board, and the sources from healthcare insurance will be radically increased, because this is a rarity in European context, because people have been paying their whole lives to health insurance companies, and at the time of the need, when they totally need 24 hours professional care, they need to pay it for the second time from their own pocket, because health insurance companies and political representations refuse to participate in funding of social services care. That's a scandal. So let me rephrase once again: insufficient financing and basically zero financing by health insurance companies, because €3.30 per day compared to €26 per day provided to hospitals. That's incredible. I mean, and the lack of staff. We are lacking 9,000 nurses in the system. Well, according to the Chamber of Caregivers in Slovakia, we are missing 7,000 caregivers. We even failed to fulfill the legal norms in terms of number of employees per number of clients and the number of professional staff. We cannot fulfill the norms, the standards, because of this lack of funding. There should be a new institute for surveillance of long-term care, because we are tired of hearing of those terrible stories from the media about how seniors in these social services facilities are tortured almost, or how troubling lives they live. So there's reform of the long-term care plan for 2023 and surveillance, long-term care surveillance planned for 2021. So again, there's 1 or 2 years not covered. There's lack of finance, the lack of staff, and there will be new surveillance in 2 years. There will be dealing and controlling the insufficiencies that are caused by lack of funding and caused by lack of staff. So there's a huge conundrum of problems. But I do appreciate that the recovery plan perceives those problems and puts the finger on the pulse and names and labels the problems that were often ignored for so many years. And what we need to also tackle is detabooization of social services, long-term care, which says that that there shouldn't be or there must not be any profit in social service facilities and long-term care facilities. It's a myth. We should face the reality. We can't make any profit. We can't even repair the roofs of our facilities, and we need to cover this from various gifts or donations. We are forced to beg for political promises, and the buildings, this, and the ministry knows that the buildings are in catastrophic situation. We were saving people from COVID, but we often are not able to save them from fire of the building, and European providers of social services have been talking about this openly, and I'm afraid that when we keep the cost efficiency in long-term care as a taboo and we will disable making profit, we'll be 20 years late. If we talk about cost efficiency in healthcare, why couldn't we talk about cost efficiency in long-term care and social services care? I mean, if someone needs 24 hours a day care, it's the most expensive service in the world. You provide housing, you provide food, you provide social care, you provide health care. A service that can only be provided by human beings. We can't digitalize. We can't use robots. I mean, we're very, very far from that. So we really need to say aloud, we need human staff. And if we want to strengthen the community services, yes, but community service can be used only up to a certain stage. At a later stage, the patient, the client needs 24-hour professional health and social care, and we need to be efficient. If we talk about healthcare efficiency and cost efficiency, we need to talk about cost efficiency also in long-term care, because a community-type facility can be established on a single floor, right? Because community care and facility is about quality of staff and quality of approach, not about number of people. So I need to interrupt. I'd like to react too as well. Yes, Ms. Fedorova, I wanted to turn to you. Mr. Dvořák, I will involve you soon. Ms. Fedorova, we've heard many things. Also in the first part when we talk about hospitals and medical offices, lack of staff. We really have thousands of workers who leave Slovakia and are caregivers abroad. The number of stories of women who would like to work in Slovakia, they don't want to leave their families. Does the recovery plan deal with the problem of how to attract back these thousands of caregivers that we need, but they are working in Austria or Germany today? Well, we need to say that these caregivers go to Austria and Germany because average wage of a caregiver is 55% of an average wage in Slovakia. In facilities, it's 70%, and this is labeled in the recovery plan. The way how to encourage workers coming back is the reform of financing. We totally agree with Ms. Ganamova, the previous speaker. So we need to essentially reform the financing and funding to ensure sustainability of the system. And we need to think about the essential change of funding. Also, we need to say that the solutions are on the table. So we need to make sure that contribution is the same for all types of facilities, so it's not public and private, and to make sure that the contribution is not calculated according to so that the contributions are calculated on a fair basis. We can talk about regulated generation of profit. These are the concepts that are already working in a number of civilized countries. That's why we often emphasize that the recovery plan is a start, because what is not included in the recovery plan certainly also needs to be implemented. We just need to start somewhere. One of the milestones of the recovery plan is the new Act on Social Services and Long-Term Care. And we will also look at the competence of municipalities. And this is statistically backed. It has a background of statistical data, so it's not just based on opinions. So if I'm supposed to talk on my behalf, this is a problem of any ministry employee in this discussion. I came to the ministry as a person who hopefully understands the problem, who understands what are the solutions, or trying to understand solutions. But I can't guarantee what we will be able to assert politically. And you know it very well because you've been facing the political pressure for many years with great courage, of course, and respect. Trying to implement something always needs also political backing. The solutions are known. We don't have to look for the solutions. We know what these solutions are. We need to apply them. I mean, all we need to do is change financing to get people back from Austria to Slovakia. We need to pay them more than €450 per month if they are supposed to work with clients from morning till late night. I apologize for interrupting you so impolitely. So now I want to join the discussion. I've been waiting here. I didn't know I couldn't be seen. So I want to react, of course. Talk about the healthcare section. So I might slightly diverge the topic from long-term care. And I always say that any reform to be successful needs three things. The first is it needs funding, because you need to pay the reform. Second, you need to prepare implementation capacities and analytical works. You need to do your homework internally. And the third thing is the political will, political intention. I perceive the recovery plan very favorably as it provides funding for something that could be started. We need to say that if we talk about comprehensive reform of healthcare, it's much, much wider than that. But if you don't start with the priorities, you can't move anywhere. So the recovery plan can be perceived as a start. Also, very favorably, I perceive that the funding of the measures in the plan is not a blank check. It's tightly linked to reforms. So it's a certain hammer smashing the concept of political cycles. So if a political leadership commits to something and wants money to do that, it needs to perform or implement reforms. That's good. The implementation capacity can be a problem. We are thinking about this actively. Talk about hospitals. I think Ms. Laponíková nailed it. Building a hospital is a much longer process than a single political cycle of 4 years. Needs to be thinking about it. So we want to define in this recovery plan an implementation capacity that would concentrate a know-how so that any hospital that wants to join the process and doesn't have their own building designers and architects, so that this know-how is concentrated. And one more thing, talking about the reforms. Very often, it's a problem of long talking. The previous ministry has 26 reform projects, 27 reform projects. You need to select the priorities and follow the priorities, stick to that. And, one of the things from the negotiations, the initial negotiations, we know very well that we are falling behind the financing of primary sphere by €100 million approximately, compared to GDP level. But these are payments that needs to be redirected to public health insurance payments, and the European Commission stopped those payments and said that we need to look at temporary investment costs. So in the primary sphere, we had to focus on support of medical offices. And I could be specific and follow up on Mr. Scholt. It's always, with reform, it's a problem of chicken or egg, you know what I mean? What was first? We've encountered with a number of professional associations, municipalities, other stakeholders, and everybody tells you different things. You need to start with the numbers of doctors. Then they tell you, no, you need to make the job more attractive in terms of competence so that you attract people. Other stakeholders will tell you, no, you need to make it financially attractive and prepare funding mechanisms so that the doctors want to go to the regions, and there are various opinions. We want to think about every one of them, but we think that we need to start somewhere at least, because the problem of Slovakia is that the plans only remain on paper and never implemented. So we want to create the financial funding mechanisms to make the financial remuneration more attractive, of having a medical office in the regions, in the countryside, so that these people know that they will survive economically. We were in touch with the Czech Ministry of Health, and they started reform several years ago. And they were going to universities, and they realized that financial attractiveness is one of the most important factor in attracting young physicians or GPs, And it's not about taking 10.5 million divided by 170 offices, and you find out that there will be 1,000 euro per office per month. It's much more complex. It's more complicated than that. So let me just react to this allocation of money. We expect that we've identified the problematic regions, and if a doctor comes there, they will receive funding for 1 year. And these are not ballpark figures. We have cost models of health insurance company. We calculated how much the doctor needs for the rent, for paying the nurse, and we calculate with 2,000 euro of net monthly wage. So that means approximately 6,500 euro per office per month. And we will support around 150 offices, which hopefully will be taken on within the framework of 5 years. And of course, the cost model is that with the rising number of patients, there will be falling volume of the contribution for this medical office. So we want to get these doctors to these black holes on the map, so to say, metaphorically, where we have lacking GPs offices. And of course, we also have approved a different scheme from the Commission, technical assistance. So we're not only looking at the wages, but we're also looking at what are the competencies of GPs, what are the payment mechanisms for GPs in relation to health insurance companies. We also want to update the network of existing offices for mechanical equipment, for wages of nurses. But this is going to be outside the recovery plan. This is going to be from standard EU funds. So you look at one topic, and suddenly it breaks into dozens and dozens of partial problems, and you need to therefore also put together the funding from various sources, not just the RRF. So I believe that the biggest problem of Slovakia is you often need to start moving. Need to start moving, and I can assure you that RRF is a good thing, good tool to move with. And I can assure you that there's been several months of analytical work, and we are already starting to approach the relevant stakeholders. Obviously, at the end of the day, it's all about the political will. I can't assure you about political will because we are only officials responsible for the bureaucracy and for timing and for setting up the tools and instruments, but the major hammer is the political will. But it's a good start. Well, basically, each of you mentioned the word implementation several times. Peter, can you explain to me what's the problem of Slovakia that we cannot implement? I'm not talking about the RRF, but talking about EU funds in general. We get the money, we start to draw them, but we can't implement. What's the problem? Thank you. Well, you opened the question of EU funds, and let me give you a couple of words to that. Besides the recovery plan, there will be, from next year, there will be 13 billion euro for EU structural funds, and the allocation within these funds is quite strictly defined from the Commission. Approximately 75% of these funds are determined in advance where exactly it should go. Healthcare represents a negative priority for EU structural funds. So we need to report the problems and insufficiencies very, very well to convince the Commission that the investments from EU funds to healthcare are essential. And this problem, firstly, was here in the past, that the officials and politicians in the past year were not able to negotiate with the Commission to ensure funding of healthcare from the EU funds. We're just not able to convince them. However, in this programming period, 2014-2020, from only around 170 million euro were provided to the healthcare infrastructure, which is not enough even for a single hospital. So it only were minor projects in reconstruction of hospitals. So for us as a ministry, it's very important for the next period, 2021-2027, to ensure that funds are negotiated also for investments into healthcare, whether we're supporting the outpatient healthcare, whether for science and research, but also for healthcare infrastructure, which is extremely important. Because from the recovery plan, the funds that we are talking about today, we have this 1.1 billion, but 870 million from that will go to hospitals. 870 million. So I have experience from working with projects from European Investment Bank. An average price of a hospital is around 300 million euro. 700 to 800 beds. So out of 870 million allocated to new hospitals, we will be able to finance approximately 3 hospitals. 3 hospitals. What is the problem, however? That we have no information about prioritization of healthcare infrastructure. In other words, where we're going to build those hospitals. That's very important for implementation. As Oskar said, we need to have clear priorities because 7, 8, 9, 10 hospitals, that's not real. We ain't going to pay that, even though that we have this need in Slovakia. So first of all, for implementation, we need courage, ability to negotiate the conditions. For example, also funding from EU funds, structural funds. For implementation, also, we need prioritization. So far, I don't want to offend anyone, but so far, it seems to me that the prioritization in healthcare and healthcare infrastructure is lacking. There's none. I can't see it. Sorry. Until the end of March, we should receive from the ministry document on optimization of healthcare infrastructure, saying which regions actually need those new hospitals. Because even if we find the money, we negotiate the money from the EU funds, all in all, in total, together with the recovery plan, we will be able to finance maybe 4, maybe 5 hospitals. But we need to know exactly by the time where the need is for new hospitals. From the major logic, it means to be east, west, south, and north or center. East, west, center, and north. I believe that would be the wisest addressing of the problem. But average time for projecting and building of new hospital takes 8 years in the EU. But we're talking about the project documentation, feasibility study, analysis, zoning plan, building proceedings, construction itself, building approvals, statutory building approvals, the whole package. I want to be optimistic, but I don't think that we could be more successful than the EU average. That is 8 years. So I don't think we will be able to build a hospital in less than 8 years. So I believe that in this respect it's going to be extremely important to prioritize the infrastructure, prepare the project documentation, which so far it's available to a single hospital in Martin, other hospitals, basically, we have nothing on paper. So from this respect, I'm rather a bit skeptical. Of course, I don't want to underestimate my colleagues at the Ministry of Health. I'm sure they will work hard and they will manage, but they need to do that. They need to work hard. And we're going to work on hand on this infrastructure project, and I hope we will we'll accelerate the project of project documentation preparation. So you're talking about building of new hospitals. You're not talking about closing down of all hospitals. But Mr. Schott, you were. Mr. Schott, may I? Good. I want to follow up on the previous speaker. What was mentioned previously. I haven't found in the recovery plan, and this concerns every single every single provider, is the equality of ownership. We are talking about building hospitals, but we're not talking about whether these are state-run hospitals or private hospitals. And in terms of primary sphere, we need to say that all primary care providers, whether these are obstetricians, gynecologists, pediatric GPs or GPs, they are private entities. They are private entities in terms of taxation and accounting. So we need to know whether in terms of this recovery plan, there's an equality of ownership put on paper. And what Mr. Dvořák mentioned, something was very puzzling for me and really problematic. We, as Association of Private Medical Care Providers or Private Physicians, we dealt with the current status quo of specialists and GPs and pediatricians in Slovakia. So we wanted to map the status quo in terms of the aspect that you mentioned, that the health insurance company provided some calculation per single office. So the association, you mentioned 6,500 euro, and this was based on the legislation, and we didn't even include any mechanical equipment, any, let's say, means of transport or anything. And this was conducted approximately 4 years ago, when this analysis was provided to the health insurance company, Všeobecná zdravotná. So this calculation is outdated. It needs to be updated. The amount is just, not relevant anymore. And just 2 years ago, when we tried to update this in terms of material and technical equipment, we arrived to the conclusion of at least 8,000 euro per month. So not 6,500, as you pointed out. And I believe that this recovery plan should have been consulted differently before it was actually in the interdepartmental comments procedure. And it's very important what was said, and it should be reiterated, is sustainability, equality of ownership, so that we saturate the GPs, the new GPs, but for me it's essential to maintain the existing GP offices, right? So we need to tackle the situation also for those doctors who are already in the regions, and we need to assist them to make sure that they stay in the regions, because if we only pay for the new offices, the old GPs, the old offices will be closed down, and in the end we will lose the offices. So sustainability is very important. In terms of healthcare budget is in catastrophic condition. We've been repeating it again and again. If we have recovery plan for 5 years, we need to provide that either the budget for healthcare or EU funds finance the Slovak healthcare also in the future, because every year we tackle the same thing again and again. Maybe the Association of Private Hospitals will agree with me that we repeatedly need to negotiate with our partners in tripartite about how much funds are missing in the healthcare. Of course, this is linked also to long-term care, social care, social services facilities. This is the priority, and this is the key thing that needs to be said. How, after those 5 years, when the recovery plan is over, how are we going to fund this? Okay, we build something, we pay for something, but 5 years down the line, we'll not be able to pay for that, right? Ms. Laponíková, maybe then Mr. Dvořák wants to react, and Mrs. Ganamová also has raised hands, so we'll go one by one. And we also get to mental health. Thank you very much. I want to return to 2 points of building, construction of facilities. Well, because of shortness of time and the political situation, I think that reconstructions could be the way. Of course, it needs to be considered in detail because the environmental aspect, which is in the background, it also makes sense. Reconstructing the existing buildings, I believe reconstructions play a very important role, and we don't talk about it because we believe that everything that's old is bad, but it's not like that in the world. I mean, in the world, they not only build new hospitals, they increase the energy efficiency of buildings, they reconstruct old buildings. This is marginalized topic, I believe. One point. Another point. Everything is about political decisions, I know, but we need to go that way. And another thing that we only marginally mentioned, and what is missing in the recovery plan is not only the motivation in terms of wages and wage compensations or increasing of wages and attractiveness of the environment, but also we are forgetting about the overlapping with the Ministry of Education, the studying programs, and this hasn't been mentioned at all. We realize that movement of competence between the respective stakeholders is essential, but somewhere in the back of our minds we know that there's potential to create new studying courses like technicians, healthcare technicians. This would be of great relevance to us, and it's totally missing in this whole recovery plan. I would like to point out this very strongly. Thank you. Ms. Ganamová, now you and then Mr. Dvořák. I want to thank to Mr. Schott because he also mentioned what we wanted to put on the table, that the whole thing is going to be concerning also private and public providers, but the recovery plan doesn't mention that. And you are all young people here working at the ministries, which is great because you're full of excitement, but please do bear with us, old guys. We're very skeptical. We've seen so many governments, so many generations. What we've seen those past 12 years was a pure liquidation of non-public sector in healthcare or social care or long-term care. So we only want to give you a message so that you understand. We are missing in this recovery plan this assurance, because just like Mr. Dvořák mentioned, yes, the political instability we are facing also today is about, when there's no assurance written, on paper, it can simply disappear. There's a new minister, a new coalition, and we will have to start again and yet again. So I believe it is essential that this gets in the document, and this is exactly what I'm missing in the chapter on investments. Yes, increasing capacities, because we know that it was underfunded. Old facilities were being closed down, new capacities weren't being established, extension of the scope of services, long-term care and social services care, which basically means supporting of healthcare facilities, because social services homes and social services care facilities basically help and reduce the pressure on hospitals. Palliative care, again, support for healthcare, so that we don't support establishing of new facilities, but these long-term care facilities will be liquidated or will be closed down. Basically, those facilities who have been, keeping the boat afloat. I mean, 45% of providers of long-term care are non-public facilities. They are fighting for years with sweat on the brow of their face. It's a bit unfair in the recovery plan, just like Mr. Schott pointed out. So we're missing this. And maybe just because you are so young, and no offense, of course, here, maybe you don't feel the need to include it there, but please do trust our intuition. We've seen so many big disappointments. There were large plans, and we only went backwards, not forward. So please make sure that these assurances are in the document so that those providers are not left out and left behind, where the primary care, long-term care, hospital care providers, private providers who have been keeping the boat afloat for so many years, despite the negative attitude of the government. And I'm a bit sorry for, I'm not sure if Mr. Dvořák mentioned this or somebody else, that there's no time for essential comments, material comments. Well, we only received the recovery plan 1 week ago or 1.5 weeks ago. So, Mr. Dvořák, you can react. Association of the association. Sorry, there's too many speakers talking at the same time. Apologies. I would like the Association of Hospitals to be able to speak. Of course, go ahead. May I? Of course, yes. Thank you very much. I apologize for interrupting you, but my hand has been raised for many years. You know, we are not association of private hospitals. There's a myth. Our organization involves 78 hospitals who are also public providers and are established under the municipalities or self-government. It also includes private hospitals, but I think it doesn't really matter. What Ms. Ganamova said was totally great. However, on behalf of the Association of Slovak Hospitals, that what the providers of social services care were experiencing in the past years, this is what we are going to experience after the recovery plan is going to be adopted, which is a huge disappointment for the Association of Hospitals, mainly the component number 11, where there was just a pure political decision that this is only going to be involving state hospitals with no communication whatsoever with our Association of Hospitals of Slovakia. We're talking about optimization of the network of hospitals, but we don't know anything about the new network. No one introduced us any plan. Even though until recently we were part of the 3 important stratification documents, the last one from Mr. Smatana, it had its logic, but no one is mentioning it, and there's supposed to be a new stratification, and no one's talking about it. What is in there? And the data from 2014, 2016 are outdated today. You can't use data from 2014 today. And when it comes to the number of beds, I need to inform you that 45% of COVID patients are in our hospitals, in our association. 55% are in the state hospitals. Where there was no COVID, 52% of hospitalizations were in the hospitals in our association, and 48%, so less than half, in state hospitals, and only 5% of the interventions were the unique interventions. We don't want to cast doubt on unique interventions, but just 5%. So investment only in selected hospitals, which are established by the Ministry of Health, is a big mistake. First of all, it's in contradiction with the government manifesto. The rules will be applied across the board for all subjects. Then it is in contradiction with the system for urgent patients of first and second type in relation to acute hospitals. We believe it is probably also in the contradiction with the Constitution, because there are 2 types of citizens now, those who are living close to new hospitals and those who are not. So there are 2 groups of citizens, privileged and non-privileged. So the so-called optimization is the key factor, and it's a purely political decision. And talking about the GPs, who no doubt are very necessary, when these GPs are going to be trained, when we are suddenly only supporting one type of hospitals, which so far no government actually took this direction. No government took this direction previously, and Slovakia is not a tiny country in terms of geography, so that we can focus on 4 big hospitals who will deal with all the patients. We're not that small. Would we be able to deal with COVID if you only had these 4 key hospitals, and almost 50%, or let's say 1/2 of these patients, are treated in our hospitals, not state hospitals. So we have 17 comments. 11 of them are material comments, so I hope that we will be invited to the comments procedure, and we also invited the European Commission or representation in Slovakia to meet with us, because we believe this is a very, very essential impact. This will have very essential impact on the provision of healthcare. And Ms. Ganamova nicely mentioned how they've been fighting for 11 years, the non-public providers of long-term services, because of poor political decision. Well, we are convinced that this is exactly the same thing that Slovak healthcare will be dealing with after this recovery plan is implemented. Thank you very much, Mr. Petko. Maybe you could tilt the camera down so that we can see your face. Mr. Dvořák, this is basically the question with most likes from Slido. Quote, do you believe that it's correct that the investments are only designed for state hospitals? Is this fair? End quote. Well, first of all, I can't evaluate the political decision that I didn't make, but you can have an opinion, right? Well, I believe that it's important before we deal with this question is to understand the technocratic principle, what criteria were selected. So let me start. I'll leave the hospitals at the end because it's going to be the biggest topic. So let me start with the offices or the personnel. We do realize the problem, but if we want to, these are all OPEX, operational expenses, that cannot qualify as the increasing of the staff. It cannot be included in the recovery plan. But at the same time, we do realize there are some educational mechanisms and subsidy mechanisms that need to be increased to increase number of staff, that we need to be pushing on the new partnership agreement, which Peter mentioned. So when it comes to personnel, we focus on education rather from the EU funds. We're going through the EU funds and creation of services like the primary medical offices. When it comes to Mr. Schott, he mentioned the cost-based model. I'm a person who is quite particular about data background. I need to have data to make decisions. And we at the ministry, we have available the payments going to medical offices. So we see what are approximately the cost-based models. At the same time, I didn't say we're going to reimburse. I didn't say we're going to reimburse 100%. We're going to scale the subsidy to make sure it's motivational so that the physicians are trying to get their patients. And when it comes to hospitals, it's more complex. The fact which hospitals are going to be built, or the decision which hospitals are going to be built, will be based on specific criteria, and the criteria are not strictly defined yet, because we need to look at the optimization of the network itself, how the optimum network is going to look at the end of the day. That's the first criteria. So we are not going to be supporting reconstruction of hospitals or departments that are not going to be used at the end. So we need to look at the preparedness. I know that the colleagues from different sections were looking at the investment preparedness of some hospitals and evaluating or assessing it. And third important factor, the projects themselves need to pass the benchmarks for the value for money department at the Ministry of Finance and benchmarks by the European Commission. So if there is a project, and the Ministry of Health will not be involved with this, but if there's a project a project doesn't meet the benchmarks of the Ministry of Finance, it doesn't meet the benchmarks of the European Commission, it will not pass. Simple as that. And a number of things we couldn't argument for the recovery plan. We weren't able to provide benchmarks and to defend our price, etc., etc. Then the things couldn't get into the recovery plan. And now the private versus public owners. Now, looking at the offices, I mean, all offices are basically private, right? So it's implicitly based in the recovery plan. So far, I haven't seen any decision of opening state-owned offices. I'm not aware of that. So, and also the political decision about the hospital was that we didn't say that we're going to be building state-run hospitals. We are going to build terminal hospitals, and the largest hospitals where the situation is most critical, this is where the money is going to go. And these are state hospitals, and it is a political decision of the leadership that they're going to prioritize these terminal hospitals. But we need to say that it doesn't mean that no money will go to private hospitals. It doesn't say. We have other beds, recovery plan, EU financing period. We want to get other beds involved, and anyone can then ask for those or apply for those projects, not only public hospitals. Follow-up care or psychiatric stationary beds, all these projects will be eligible, or all owners will be eligible for these projects. Mr. Balik will confirm that. We also have the new EU fund period, 21-27, where the conditions of the European Commission itself, looking at the other project where the hospitals were being built, that there's a condition that the institution shouldn't only provide acute healthcare, but also it should somehow involve science and research. And this very much expands the set of hospitals eligible. So it must be connected to some educational institution. So the decision itself, yes, it's a political decision, firstly, but secondly, it doesn't say black or white, like we need to only be putting money in the state-run hospitals. There's a number of other criteria, 4 criteria that I mentioned, and we also need to be looking at other Euro funds, because first, you need to make optimization of hospital network. And this optimization consists of several steps that are already being made. First, analysis of consumption. Based on this analysis, there are future predictions. How many beds, where? Acute beds, follow-up care beds, specializations. We're talking about professional societies. Then we prepare hierarchization of hospitals, which is being done, which hospitals should provide which services. And then the part which is most controversial, and we're going to do this, where specific points will be determined. Based on these points determined, there will be investment plan of hospitals, where, which points, which locations hospitals should be built, what should be reconstructed, what should be supported. Now I know that the colleagues from my other sections are already working on this. They are also looking at the investment preparedness, and this investment plan needs to be complementary with the recovery plan, not the other way around. So we have EU funds, we have the recovery plan, we have maybe some returnable funds, and all of these projects need to be compliant with the requirements. So you need to put together this mosaic from a number of pieces. So to illustrate, this is not black and white, that we just decide only state and not private hospitals. There is a certain degree of political decision, but there's a great number of other technocratic criteria that I wouldn't simply unify from a outsider perspective. Okay, one thing we haven't analyzed, that's mental health, and that's a very important question, especially today after 1 year of pandemics. So now, finally, Robert Babila will join us. I apologize that it took so long. Slovakia has been neglecting the mental health for many, many years. For the first time in the history of Slovakia, we see this mental health as a part of government manifesto and also recovery plan, the network of psychiatrists and therapists, etc., etc. How do you actually evaluate this section of recovery plan dealing with mental health? Thank you very much for inviting me. I believe that there should be mainly the president of the Slovak Psychiatrist Society sitting here, maybe someone from the Mental Health League. But in terms of specialization, I'm a pharmacoeconomist and a public healthcare provider. But I was lucky to deal with a few analyses dealing with mental health. And if we talk about this topic, I always look at these things from 2 perspectives. Well, allocation, efficiency, and value. Everybody's talking about it, that after COVID, it's quite logical that we will need to improve how to invest money in mental health and to focus more on the value. So what value is produced and what value we are receiving for those money. And to be quite specific, when we were looking at the daily daily psychiatric stationary offices. We were daily psychiatric care providers. We reduced hospitalization in 3 years by 80%. Direct costs for treatment by 30%. Inability to work, 80% reduction. This is a specific value that unfortunately is missing in the plan. All professionals that I advised with before this webinar told me one major thing. First of all, mental health, it's great that it is included in the plan. But the second thing, that there's lacking communication. When we talk about the value, and I'll return to the hotlines that help patients with psychiatric problems or mental health problems. There's a state-run hotline supposed to be established, which will basically destroy the existing hotlines. Instead of getting advantage or using the existing value, why not invest $500,000 somewhere else where it really makes sense, where there are professionals, where there are people with experience. But suddenly it seems that all these private hotlines will be destroyed economically, and there will be a state-run hotline which should be providing services which are already being provided. And this $500,000 would provide a 24/7 hotline for at least one year. And we are in the middle of COVID pandemics, and we're surprised that we have so many deaths, and we don't know why. Well, I tell you why. As long as an old person lives in isolation, their mental health is dramatically declining, and by declining in their mental health, there's an increased likelihood of any infection, including COVID. They may be infected with COVID, and with poor mental health, there's much higher likelihood of death if they have poor mental health. Talk about psychological support to healthcare providers. Healthcare providers, professionals, they're going through a war. They are at war. You can really compare it with wartime. And the healthcare providers who go through this period, they need psychological support. And they will need it also after the pandemic subsides, when it's suppressed. And we do have capacities for that, but these capacities are not adequately financed. They're not funded. And looking at the depression, the past 3 years, we have direct costs to treat depression increased by 1 million. In the past 3 years, 1 million plus. Indirect cost increased by €4 million for treating depression. So the field of mental health, once again, it's great that it's included in the recovery plan, but there's missing much more intensive communication between the ministry and the people who understand the issue of mental health, who understands how it should be done and why the respective steps need to be done. I lecture at university. I have 29 years of experience in healthcare across various positions, but one thing I realized when I did a serious analysis, Mr. Dvořák pointed it nicely, they have data. Well, I tell you one thing. We analyzed strokes and data from strokes, and the Ministry of Health data and our data differed 17 millions from what we received from the insurance companies. So what's nobody mentioned is that we don't even have good data. And if we don't have good data of which we can be sure that they are close to reality, then we can't manage because we don't know what is going on. And since we are going to do analysis, we need to do the analysis directly with the insurance companies, so those who are payers, healthcare payers. But second thing is that the analysis to have a value needs to be also performed with specialists in the given area. And this is something we can show to the ministry or any one of you to present what's the situation and where we could be going, also in the field of mental health. You mentioned number of benchmarks or economic parameters and indicators. We calculated everything. We calculated ROI, we calculated benefits, NPV. We even presented it to the ministry, but no one cares. No one's interested in our data. So I don't want to be rude. I want to only criticize. I mean, it's easier to be critical if you are not responsible for anything, I know. But if we do things, we want to do them well, and we want to do them so that we get somewhere. That's it from my side. Thank you. I think Mr. Dvořák wants to react. So, Mr. Dvořák, do you want to? Yeah, just briefly. A number of these questions could be answered by my colleagues who are directly dealing with mental health issues, which is not me. I don't want to bore the audience, even though I speak in great detail. I know. That's why I don't work with data from National Health Information Center. I often work with the data from the providers or payers. So we're the only section that has comprehensive data on primary medical office sphere from the whole Slovakia. We took data from health insurance companies, we cleaned the data, we integrated them, and we found out about the situation. Even the health insurance companies don't know about the other company, So we have data from all health insurance companies, and we have it integrated. So I believe that, yes, this great volume of tiny work, which is not mentioned about in relation to the problems. Of course, you need to deal with the quality of data. We need to integrate data. You need to, and I could tell you a number of details that's not mentioned at all. You only see the tip of the iceberg, but I don't want to mention that about the whole volume of work, because I don't want to bore the audience. Okay, we've had 90 minutes of discussion, and there's a lot of questions. So let me, we've already asked the question with the most votes that related the state versus private ownership. The second question also deals with the same topic. So this is really resonating. And there's a question from Mr. Stanko. What's the difference between constructive comment and ideological support of a state-run public facility? Will you also support private providers? Well, the second part of the question, well, we already commented on this. So constructive comment, I meant the constructive comment based on the directive, clearly formulated change or amendment of the written material that we are submitting. So if there are opinions or recommendations or suggestions which are not justified, we don't have to react to them, but we thought that we should comment or respond to every comment, to every stimulus, but it's important that the party submitting the comment recommends a specific amendment, so modification of text or deletion of a certain item or piece of text or words, so that we can evaluate the technical side of it. So if there's just ideological opinion or a comment, it doesn't actually fulfill the classification of an amendment or comment from the legal perspective, right? So, Mr. Dvořák, construction of a state hospital is a long process. So, isn't it better to involve a PPP project, public-private partnership projects, more efficient than state-run process? Mr. Dvořák, could you repeat the question, please? So, the question is, since building of a state-run hospital is a politically long process, isn't it more rational to classify the project as a PPP, public-private partnership, Bory Hospital versus Rásohy Hospital, as an example? Well, since we've had some attempts for PPP projects, I believe this is not, I have to tell you, this is not my decision, so I can't tell you what is the political preference or official statement of the ministry. But as far as I understand, the answer is no. I think that the ministry doesn't want to take this route at the moment. But what's your opinion? We're not asking about the political line. Well, I don't have a definite opinion in this, because for every single hospital you need to evaluate this individually. And I can't comment generally. Ms. Lapuníková? Mr. Dvořák nicely passed the ball to me. Not sure if he realizes, because if he says that we need to talk individually about every hospital, but if a specific hospital in question is the Roosevelt Hospital in Bystrica, which has a project that passed through all amendments procedures and comment procedures and the value for money section of the Ministry of Finance, we know what's the allocated volume of funds, which takes into account the indexation, of course, because since the public procurement was finished, there's been certain time elapsing, we need to be talking pragmatically, but if a project is ready and it is feasible, then politically it would be, well, correct to grasp the project and take it and implement it. Because such an opportunity that something is ready and prepared and is not executed, even though it's gone through all the comments procedures, then it's waste of human potential, waste of money, because an incredible number of people wasted a great number of their efforts and energy in a long period of time, which was key for us, 4 years. So we invested so much work in this. Basically, there was no real obstruction, there were no real mistakes detected. Then I believe it would be wise to at least put this idea in practice, and which is feasible. Thank you very much. Question for Mr. Dvořák and also for Petr Balik. Actively thinking about implementation is not enough. You should have tested the processes so that you know what's happening as of 1st of May. What are you going to do on the 1st of May? Perhaps I leave the word to Oskar, because he is in charge of the healthcare. Well, look, I'll be very pragmatic. We came to the ministry, and most of the capacities, well, the first important factor, there were no project pipelines with projects ready, which could be executed, which would be put into a machine and processed. There were none. Then the recovery plan came as a lighting from a clear sky, so no one really expected it. So we had to start from scratch. I'm not going to talk about hospital because there's other actors responsible for that, my colleagues from different sections. So we wanted to build on something which was some work which has been done previously. We didn't throw everything away, but in everyday life of the ministry, I can see that the COVID is setting the tone, and it takes so much capacity of the ministry, and the implementation capacity which had been here and which we believe were insufficient. Even though we're supposed to be the major fighter against the pandemics, we are actually the second smallest ministry of all, by the way. So that's reality. What we do is that we try, according to our best, we try to do the best job we can to improve the implementation capacity of the ministry. I understand the skepsis. I understand why you're skeptical. I understand, and I share your skeptical approach, because this political situation can change any day. But on the implementation level, on the official technocratic level, I can assure you that we are doing the best we can, and following the best examples from abroad, we see the number of hospitals wanted to order the services, talk about digitalization services, architectural services, project services. They wanted to order the services individually. They would have to otherwise build their own teams for that. So what we're trying to do for hospitals, so we have this implementation agency ready for them, which concentrates the know-how, which focuses when one project in one hospital is over and implemented, then it can turn to another hospital. It can save money. So this is a totally new thing that we are doing that hasn't been there until then. Okay, next question. What's the preparedness of project for digitalization of healthcare, and are there clear priorities? Digitalization of healthcare. Anyone? I may answer. Can you hear me? Yes, we can. Thanks. Well, in terms of the previous questions, what we're going to do on the 1st of May. Within the scope of the assistance of the EU, so-called REACT EU, the post-COVID assistance, we've earmarked 44 million for project preparation. So already now, we are starting to decide where these sources will go, and the objective is to help these new hospitals also from these sources that Oskar mentioned. And the second part of the question about digitalization, the Ministry of Investment and Regional Development and Digitalization was in close touch when preparing the concept of healthcare reform and digitalization. We have devised various tools supporting telemedicine, central information system for hospitals. Also, there is a shared system for sharing of imaging, diagnostic imaging like CTs and MR, which I believe is a huge issue in Slovak healthcare. You perhaps know this from your own experience, that you see 3 different specialists with a broken leg, and 3 different specialists will make the same X-ray or MR. Systems are not interconnected, so it's a huge waste of resources for these diagnostic imaging procedures. So this should be prevented by this system of shared imaging, which is under the scope of digitalization, but the bottleneck we are facing is the implementation. Yes, there were efforts in healthcare digitalization, within the scope of the e-health project. I believe that the e-prescription is working really well. The e-prescription of drugs. It took maybe 15 years to get there, so that the physicians can prescribe drugs electronically, and there are other projects which are about to be launched. But we need to make sure this is complemented by the recovery plan projects. E-health is starting to work fine. It's important that this hardware that it's being built on is actually outdated. So we need to be talking about the new hardware equipment, which is the basic building block of the whole e-health system in Slovakia. And what is really important in digitalization of healthcare is the so-called digital competence and digital skills of healthcare providers or healthcare professionals. I have healthcare professionals in my family, and I have to say that the digital skills of nurses and physicians are very far from ideal, and there is a huge backlog or skill depth, if you like, and the recovery plan is missing on this. We need to focus on supporting the education of healthcare professionals so that they are able to use the systems. If you talk about telemedicine, if you're talking about the sharing of these diagnostic images, it is important that the physician and the patient are able to, for example, at home, with the comfort of their home, they could use electronic phonendoscopes that can generate data for the physician, and based on these data, the physician can diagnose the patient remotely without the patient actually seeing the doctor. The Ministry of Investment is trying to design a measure included into recovery plan is the support of digital skills for seniors as a marginalized group, or seniors and marginalized groups. We want to support them not only with soft skills, digital skills, trainings, but also support them through hardware equipment purchase, whether some senior points or some other senior pods or other equipment that can help them in socialization, especially in times of pandemics like now. It can also help them to consult their physicians and GPs, and it can prevent that they have to, waiting in the offices from 5 or 6 in the mornings just to have the recipe filled in by the GP, So these are all the measures in the recovery plan. And one more thing I want to say, that the recovery plan is not the only source of financing. We have EU structural investment funds, so it's going to be necessary to look for and follow up and create synergies between the recovery plan, structural plans, And even though if something wasn't included in the recovery plan, don't worry, it can still be included in the operational program linked to the respective EU funds. The marginalized Roma communities, maybe it would have been quite nice if they had a place to live and roof above their heads and before they receive tablets and notebooks. Nevertheless, we are about to finish soon. Mr. Dvořák, you are you're the busiest respondent today. It's a question for you, logical question, I suppose. You mentioned about the whole recovery plan, and there's a question. If you first define investments and then you want to conduct a dialogue about the new network, how can investment plans precede the reforms? Well, no, I said that the investment plans is only devised after the optimum network is defined. So we've agreed with the European Commission that we defined the beds and benchmarks, but the final investment plan will be only approved after the optimization of network so that we can prevent investment in a department which is going to be closed down anyway. So the answer is yes, we are thinking about it, and no, it's not like that. The stratification is now called optimization now. I mean, shouldn't it be ready by now, and so that we know where we are going to invest? Well, of course, it should have been ready by now. It could have been approved 1 year ago or 2 years ago. But stratification is basically all on the table since 2013, has been on the table since 2013. But the previous ministers and previous political generation decided that the whole analytical work needs to be done in-house again, especially when it comes to consumption. So we basically followed the tasks and assignments given by the ministers to perform the analysis in-house. The analysis of consumption has been prepared, and now the analysis and all the other steps are following. The optimization of network is new, and based on these in-house analysis that we've already developed, is not going to be fully identical with stratification. It's going to be different. Okay, so we'll have to wait until this government if this government survives, and to make these political decisions, put them into practice. Thank you very much for participating in today's discussion. This is certainly a topic we could discuss for hours and hours on end. We could certainly dedicate much more time to all the other measures that haven't been discussed yet. So one by one, I'd like to greet you and thank you. Ludmila Majlatová, Economic Advisor, European Commission representation Slovakia, thank you. Oskar Dvořák, General Director of Section of Reform Agenda at the Ministry of Healthcare, thank you very much. Petr Balik, General Director of Section of Innovation Strategy, Investment and Analysis from the Ministry of Investment, Regional Development and Digitalization, thank you. Lukáš Stanko, Project Manager from Section of Recovery Plan, Ministry of Finance, thank you. Katarina Fedorová, General Director from the Section of Social Policies in the Ministry of Social Affairs and Family. Thank you. Bye. Miriam Lapuníková, Director of Roosevelt Hospital. Thank you. In Banská Bystrica. Thank you too. Marian Schott, President of Association of Private Physicians. Goodbye. Anna Ganamová, Director of Association of Social Services Provider. Thank you. Thanks for listening to the voice of the professional practice, at least here. And we also had Mr. Petkov from the Association of Hospitals of Slovakia. Thank you very much.